Good night, everyone. So let me say this slowly for the people in the back. Just because a wound is pink does not mean it's healing. This is not about giving up hope, but I do not like when I hear a patient wound getting worse and they're like, oh, but they say that it looks good because it's like pink. And I'm like, but it's not closing and it got bigger and I can see deeper structures. So, yeah. That doesn't matter. But if the wound is getting bigger, I can see the tendon, then no, that is not improvement. That is not granulating nicely. And pretty much it's absolutely not okay to just watch it, just sit and watch it. Okay. Pink tissue can lie, size does not. Okay. And tendon exposure rewrites the rules of wound care when it comes to that. The deeper the wound, the more advanced the wound care, in my opinion. Okay. So let's get into it. It's very late. I'm exhausted. Pretty much had a whole marathon today. So it looks pink, so it must be healing. I'm going to dismantle that myth. What does pink actually mean? Pink tissue represents typically granulation tissue, capillary profilation, fibroblast activity, and inflammatory signaling. But the problem is that pink tissue can exist in hypoxic wounds, a colonized wound, a mechanically stressed wound, a wound with zero chance of epithelial closure, and a wound actively breaking down, then it's rebuilding. So pink is just a color. It's not a diagnosis. So keep that in mind. So what happens when you do see the tendon? Pretty much changes everything. The tendon is exposed. We already know the tendon is avascular, but you're no longer dealing with a simple wound, a superficial wound, or a wait and see wound. It's not going to be that once we see the tendon, okay? It should never be that even when you have any small wound, but I'm just saying, yeah, we're not going to do that wait and see technique. So you're dealing with, once you see a tendon, an avascular tissue, high risk of desiccation, so it's going to dry out, loss of gliding function, like gliding function, direct conduit to deeper infection, like deep soft tissue infection and deep space infection, and it is a limb-threatening scenario. Remember, tendons have minimal blood supply. Tendons Tissue does not granulate easily over tendons. They do not granulate easily. They do not epithelialize on their own. It becomes necrotic when exposed to air. Like I said, it desiccates very quickly and are highly, highly susceptible to infection and rupture. Remember, I said I had to cut a tendon out? I mean, I've done that quite a few times already, and the tissue is able to granulate very well afterwards because once the tendon is really infected and it dries out, why is it there? You have to think about biomechanics, how it's going to affect it, because if it does, and then it pretty much deforms the patient's foot, and then there is a biomechanical imbalance where the foot either is varus or valgus. The more time it ends up in a varus, but that's a whole different story. So the most important questions when you see a wound getting pink and nothing going on is the wound getting smaller. That's something that you painfully need to be clear. Is the wound getting smaller? If the wound is pink, but the wound is getting bigger, it's failing. Healing wounds, they shrink in size, they shrink in surface area, they reduce in depth, they show edge advancement, and they show epithelial migration. I always like watching the little baby cells begin because I'm like, oh, well, when I see you next week, you're gonna be not there anymore. There are gonna be other new baby cells, and you're getting like more mature. I know that sounds so weird, but they're baby cells. Okay, so what is a failing wound? A failing wound is an enlarged wound. There most likely will be undermining, the wound has stalled, there's exposed deep structures. It creates false granulation sometimes, okay? So color does not predict the outcome. The size trajectory does. And we already talked about when it comes a chronic wound, but a wound is considered chronic when it fails to progress through the normal stages of healing, it shows no significant size of reduction, and it does not respond to standard of care. Commonly time-based definition for chronic wound, like I said, more than 4 weeks without measurable improvement, more than 6 weeks if it's stalled, and 8 to 12 weeks is a non-healing, fully chronic wound, okay? A wound can be functionally chronic in 7 to 10 days if the tendon starts getting exposed, the offloading is inadequate, infection is present, ischemia exists, and biomechanics are ignored. So, here's some non negotiable rules when it comes to tissue. One, depth trumps color. So, a shallow black wound can heal, a deep pink wound can kill a limb. It sounds very contradictory and paradoxical, but a shallow black wound, like let's say it might be like a S scar. S scars are deeper than that, but possibly could be put some honey on it, oxidative debridement, things like that. But if it's like a deep pink wound that's already stalled, it just gives it more need or gives the bacteria or infection more time to just escalate. So when we see a tendon, exposed tendon, that would equal escalation, and I don't know why I'm thinking the word escalation. So this is not conservative care territory. When you see exposed tendon, this is not conservative care. This is not, "Let's try another dressing" territory. This is not, "Come back in 2 weeks" territory. Like I said, this is not a wait and see category. This is aggressive offloading depending on the area of the wound, moisture control, not wet, not dry. You have to have balance, biological consideration, possible surgical intervention, and a multidisciplinary involvement. So if the wound is growing, like I'm talking about getting bigger, okay, it's pretty much a losing game. Enlargement means mechanical failure, vascular failure, infectious failure, and failure of the provider to get this wound to be smaller. So we have to figure out how to get this wound smaller. So chronic wounds don't need more time. They need a new plan. So if the wound hasn't changed in 2 to 4 weeks, let's give it about four, stop repeating the same treatment. That's what I had to do. Reassess the diagnosis, reassess the pressure, reassess the blood flow, and reassess the infection. So worst outcome when it comes to things like that, people would be like, it was pink, it looked clean, the doctor said there was no odor, and it didn't hurt. But that's where things can get masked and it can just become limb-threatening out of nowhere. You have to remember diabetic wounds, they can lie because of the neuropathy. They can feel better when they're not. They can look better even when they're not, okay? And they can progress slightly. And you have to remember with diabetes, you can have neuropathy plus ischemia and then also the pressure. So that can cause a lot of delayed recognition, false reassurance, and a catastrophic delay. So that's why it's such an important thing to take time to reassess and frequently. So, and we're not talking about like OCD or anything like that, but you have to be diligent. Diligent, especially with diabetic foot ulcers, any wound, but diabetic foot ulcers, be due diligence, okay? Like I said, by the time the tendon is visible, the clock is already ticking. You shouldn't be just sitting and waiting and seeing what's going to happen, okay? So, how to heal, how healing a wound with a tendon should act. So, if a wound has an exposed tendon and healing is truly happening, I mean, to be honest, it's very night and day. The tissue will granulate over it. It wouldn't be a problem. You will notice the difference. But if that tendon is hindrance to the wound granulating and actually increasing in its getting lesser of depth, then you're gonna have to remove it depending on the biomechanics. But what I've seen night and day, I've given the tendon about I usually give a tendon about, I think maybe 4 weeks to granulate over, and if it really is, like, a deep wound where the patient's not healing, like, literally on that side, yeah, I will move the tendon, and like I said, it's like night and day. Next week, you will see the granulation. It it's like it was pretty much a cement block blocking all the healing at that moment, okay? We're not saying you have to use clinical judgment to remove the tendon, okay? And pink tissue isn't just what I call cosmetic. So when the doctor says it's pink, it's healthy, ask other questions. You got to be more particular. You have to figure out what's going on because if it's not decreasing surface area size, what else is going on? And I know this episode is really quick. I had a marathon of a day. It's been exhausting today. Crazy. I have a big day tomorrow. So, quick question. Let's use some high yield board questions. So, question one, a diabetic patient presents with a plantar forefoot ulcer. The wound is pink, moist with granulation tissue, but has increased in surface area over 3 weeks. There's no odor, there's no drainage. What is the most appropriate interpretation of this? That the wound is still failing. The wound is failing despite the granulation. Granulation with outside reduction is still failure. Which finding most strongly predicts wound healing? It's going to be like board answer even in my opinion, it's going to be decreasing a wound dimension. Size beats appearance. You know what? I don't know about that answer, but we'll get back to that. I'll do more in depth than that. A wound with exposed tendon but appears to be pink is best described as high risk for desiccation and infection. Okay? Tendon exposure in a wound is never benign. Just keep that in mind. That rhymes. At what point is wound considered chronic? Just keep it in mind. 4 weeks, 4 weeks. Okay? If it hasn't reduction in size by 50%, they use 30 to 50% within 4 weeks. Yeah, chronic. Behavior defines chronic cystity, okay? As well. Which mechanism allows granulation tissue to persist in infected wounds? Which mechanism allows granulation tissue to persist in infected wounds? It's going to be the chronic inflammation fuels false granulation. A pink wound with rolled edges. What is the rolled edges called? The epibole, me likey. And no epithelial migration. So a pink wound with rolled end edges and no epithelial migration most likely indicates biofilm in a stalled wound. 7, what factor most commonly converts granulation tissue into tissue breakdown? Pressure and shear force. So just this is such a quick episode. I will definitely go more in depth probably tomorrow. But granulation tissue is activity, not just a victory. And if a wound isn't getting smaller, if the tendon is exposed, if the pressure isn't corrected, and it's just pink tissue but it's stalled, we have to think of a different plan. So take home message is pink does not equal progress. If the wound is getting bigger, that means it's getting worse. And tendon exposure changes the whole diagnosis in the game. And chronic wounds are defined by their behavior, not just by their time. And delays always cost the patient their high risk. Remember, time is tissue. So next time somebody just tells you it looks good, it looks pink, ask them, is it smaller? Okay, size matters. Because if the tendon is showing and the wound is growing, what else are we doing? The wound's not healing. So it's the wound's pretty much telling you, please change the game plan for me because I'm not satisfied. So that's how it works. But this is diabetic foot files. It's pretty late. I am exhausted. I just had to get one out. So take care of your feet because they take care of you.